This is Dr. Hadi Al-Nizi. I'm the chairman of the Scientific and Organizing Committee for the DD21. Lots of people ask me what's special about this version of the deep dive. Well, I can summarize it in 3 points. Number one, it is very clinically oriented, and we built it around the 6 domains of model of care and themes. So for example, if you came day one, it's going to be urgent care, followed by chronic, women's and children, and then miscellaneous. For all the practitioners in the primary care across the country will find it quite relevant to them. Number two, we stay committed to our promise to our trainees to make this conference very well oriented to their exam. So those who are sitting for any promotion or final exam in the field of family medicine, they will find this conference quite relevant to them. Finally, this conference endorsed by the all major and leading organization in the country. The holding company, شركة الصحة القابضة, CCHI, المجلس الصحي السعودي, and the Saudi Commission for Healthcare Specialty. So I can say it is the largest gathering for family, physician, and primary care across the country. See you all on June 11.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على خير خلق الله أجمعين. أسعد الله أوقاتكم بكل خير، وحياكم الله أجمعين لهذه الأمسية من أمسيات ال Evidence Based Evening بعد توقف لفترة الصيف وفترة العطل والاختبارات. نحن نعود بإذن الله ببداية قوية. It's I'm honored tonight to welcome our very special colleague, expert in the field of the family medicine, field of diabetes, field of endocrinology, to address a very, very important topic about caring for our patient with diabetes. It comes time that we in primary care go beyond the basics of just starting patient on the old generation that may or may not be the best option for our patient, and jump in to provide the best available care through the different available resources. We as family physicians, we always start with the life intervention. We start with the diet and the exercise, but we all know it comes a stage where a special intervention are required, and there are many currently available to care for our patient with diabetes. This evening, it's my great pleasure to welcome our expert panel, Dr. Walid Al-Bakr, who is Associate Professor of Medicine at College of Medicine at Imam Abdul Rahman University. He's an endocrinologist, diabetologist, very well known and in the field. It's great honor and pleasure to have you, Dr. Walid. Also, we would like to welcome Dr. Saleh Al-Nas, who is a consultant, family physician, and diabetologist at the E1 cluster. Additionally, we have with us Dr. Umar Al-Amoush, a consultant family physician from Johns Hopkins Aramco Healthcare. Shortly, we'll be joined by a fourth panel of this night evening, Dr. Hussein Al-Graini, who is a consultant endocrinologist, section head of endocrine at Al Musa Specialist Hospital in Al-Hasa. So the theme of this evening gonna be about GLP. So we have lots of event and discussion in the past about different intervention. This evening, we decided to talk to you about the GLP and its potential use, benefit, side effect, concern, and we're going to drill down to the level of the frontline clinician. Before I start the night, I want to make sure that you all, my respected audience, are aware of the largest family medicine gathering that is coming in 2 days. So this coming Friday, June 11, we will start our deep dive conference, which is the largest conference for family physician in the area. This year we built it around the 6 domains of model of care. So day 1 gonna be urgent care, followed day 2 by chronic, day 3 about women's and health. Then we conclude day 4 by the other aspect of model of care. It is our great honor and pleasure that this conference is supported by all the different decision maker and stakeholders in the country. by the Saudi Commission of Healthcare Specialty. Prophet Rakban will be presenting as one of our panel keynote speaker. Dr. Shabab Al-Ghamdi, who is the Secretary General of the Cooperative Council for Health Insurance, will be presenting. Dr. Khalid Al-Gmeizi, representing the holding company, and Dr. Khalid Al-Abdul Karim, who is representing the Ministry of Health. It's great pleasure and honor to invite these keynote speakers who are gonna enrich the discussion not only about the clinical but the future of the family medicine in the coming years. Without further ado, I would like to welcome to the stage our first speaker, Dr. Walid, who is gonna take us to the basics of GLP. Dr. Walid, what are GLPs? What we need to know to start talking about GLP to our patient. Share with us the background of the GLP, their mechanism of action, and what you feel we need to know at the frontline clinician. Dr. Walid, the floor is yours.
Thank you very much for a very nice introduction. I would like to thank all the organizing committee for actually inviting me in this meeting. I was actually assigned to talk about introductory lecture about the GLP, the mechanism of the GLP, and about the pharmacokinetic and dynamics of the GLP, and to open the door for my colleague to talk about more about the trials, about the GLP and the role of GLP in treating a patient with type 2 diabetes. So let me start actually talk about that. My objective, we're going to talk, as I mentioned, about what is GLP, what is the physiology of the GLP, what the
كأنه الصوت انقطع عندك دكتور وليد. طيب فيه الكونكشن بروبلم اللي صارت مع الدكتور الوليد. And further, not to delay this evening, we'll proceed to Dr. Saleh, and we'll get back to Dr. Walid once Dr. Saleh is over. Dr. Saleh, you gonna share with us different evidence-based medicine reviews about utilization, potential use of the GLP. So the floor is yours, Dr. Saleh.
السلام عليكم. مساء الخير جميعا. I'd like to thank you, Dr. Hadi, and the organizing committee. Okay, we'll start with talking about the GLP. And you know, could be considered the hot topic for the diabetes world. Everyone is talking about GLP-1 receptor agonist. Some patients, they refer it as the magic medication. We have a medication to cure diabetes, some patients saying, and it's curing the diabetes, and it's giving once weekly. So all these words said by some of the patients. Let's see what's unique and special about GLP-1 receptor. It's not necessarily true what every patient is saying about GLP-1 receptor agonist. We'll try to talk and to correct some misconception and to identify what's the advantage and disadvantage of this GLP-1 receptor agonist. What's unique about it, it's given once weekly. Okay, it has minimal risk of hypoglycemia, and it has some of the agent has cardiovascular benefits, some of them, and it promotes the weight loss. Okay, so all what patients care about it, their weight, at least not to gain weight, and if they can lose weight, it's more advantage for them. The compliance, some of the agents can be given once weekly and have minimal risk of hypoglycemia compared to the insulin, the injectable insulin. These are the advantage of it. Another advantage, as you see from this ominous octet, 8 factors leading to hyperglycemia. See how many factors, and the GLP-1 receptor agonist targeted multiple pathophysiological defects which lead to hyperglycemia in people with type 2 diabetes, compared to metformin, which target only one pathophysiology. The GLP-1 receptor agonist almost targeting 6 pathophysiological defects. The other things, which is usually referred by some patients, it's like magic, because if you see these trials, the black square is GLP-1 receptor agonist, and the white square is the placebo, and the triangle, the healthy control subjects. What they did in this trial, they infused glucose intravenously, and they measured the insulin response ratio, okay, to see the effect of GLP-1 receptor agonist into beta cell function. You see what's happening. This is the placebo, and you see the black square. Those who injected with GLP-1 receptor agonist, they get insulin response to glucose comparable to healthy subjects, okay? So GLP-1 receptor agonist can restore the beta cell function. It's like magic, okay? This is another trial. You see the green one. The green one, this is after 12 weeks of injecting GLP-1 receptor agonist. It's comparable to the blue square, the healthy non-diabetic people. So their beta cell response, their insulin secretion response is gonna be similar to healthy subjects in matter of 12 weeks. So that's why some patients, they refer to it like magic. So this is about the one of the advantage of this class of medication. Usually it's divided into Exidine 4 based or human GLP-1 based. Why is that, or why is this classification? You see here the homology and the antibody reactions. And those who have the GLP-1 receptor exenidine 4 base, the exenatide once weekly, the lixisenatide and exenatide twice daily, they have more antibody reaction and more injection site reaction. And this is lead to immunogenicity, and the immunogenicity attenuate the glycemic response to this medication. And you see the first 3, they don't have cardiovascular benefit, and their efficacy of glucose lowering is weaker compared to the other, the human GLP-1, the liraglutide, the dulaglutide, and semaglutide. Okay, this is one. Another things we'll talk about the dosing. Usually the exenatide is short acting, giving twice daily. Lixisenatide is giving once daily. And the liraglutide also is giving once daily, starting with 0.6, then increase to 1.2 after 1 week, and if necessarily increase up to 1.8 milligram. This is the approved dose for people with type 2 diabetes for glycemic management. Okay, and the exenatide is giving once weekly 2 milligram, and the dulaglutide also it's giving once weekly. We have 2 forms: the 0.75 milligram once weekly, or the 1.5 milligram once weekly. In the Ministry of Health, the available one is the 1.5 milligram once weekly, and you can start right away with this dose. Okay, and the semaglutide, you start with 0.25. After 4 weeks, you might increase to 0.5 and 1 milligram if necessary for glycemic management dose. About the renal impairment, as you see, most of these agents, they don't require dose adjustment. And just to be noted, there is limited experience in severe renal impairment for all GLP-1 receptor agonists. Why is that? Simply because most of the trial conducted for safety of this medication, they exclude who's having GFR, estimated GFR less than 30, and some trials excluding who's having estimated GFR less than 15. So we have limited experience in patients with severe renal impairment. So it's generally not recommended to be initiated in those who have estimated GFR less than 30. Okay, this is a meta-analysis comparing different GLP-1 receptor agonists versus basal insulin. Basal insulin on top of oral medication. You see GLP-1 receptor agonists, they have favorable effect in the A1C. And compare GLP-1 receptor agonist compared to the basal bolus, it's similar in A1C reduction. Okay, in terms of the change of fasting plasma glucose, as you see here, the basal insulin is superior to GLP-1 receptor agonist in reducing fasting plasma glucose. In terms of body weight, the GLP-1 receptor agonist is associated with less weight gain compared to the basal insulin and compared to basal bolus insulin. Okay, so this medication, we have two agents get FDA approval for weight management for those who don't have type 2 diabetes. Recently, we get the FDA approval for the semaglutide with the dose 2.4 milligram injectable once weekly for weight management. Okay, based on this step clinical trials, as you see, it has a huge, significant, clinically significant weight loss effect. Okay, so based on this study, the FDA a few days ago approved the semaglutide 2.4 milligram to be used in people with overweight or obesity without type 2 diabetes. We have one agent approved in children or in pediatric aged 10 years to 17 years, and the FDA approved the liraglutide to be used in pediatric aged 10 years to 17 years based on this study. In people with type 2 diabetes, it's pediatric with type 2 diabetes. How the A1C compared between the different GLP-1 receptor agonists? The highest one of producing lowering the A1C and lowering the weight, okay, is the injectable semaglutide associated with up to 2.2 A1C reduction and up to 6.5 milligram weight loss. Okay, after the semaglutide, we have the liraglutide and dulaglutide. Okay. In terms of the common side effect, the GI side effect, commonly the nausea, vomiting, diarrhea, is exenatide once weekly associated with the minimal or less frequent GI side effects, specifically the nausea. Okay, so this is the meta-analysis comparing different GLP-1 receptor in terms of nausea, vomiting, diarrhea. You see here, lexazenatide compared to exenatide twice daily associated with less nausea and less diarrhea. And it's comparable in terms of vomiting to the exenatide twice daily. If you would compare exenatide once weekly to liraglutide, exenatide once weekly associated with less nausea compared to the liraglutide once daily, and comparable vomiting and diarrhea. Okay. So if you would compare dulaglutide to once weekly to liraglutide once daily, dulaglutide associated with less diarrhea and comparable nausea and vomiting. So liraglutide and dulaglutide, they have comparable incidence of nausea and vomiting, but less diarrhea associated with dulaglutide compared to liraglutide. This is from this meta-analysis. Another side effect, we have talked about the immunogenicity, the antibody reaction, which attenuates the glycemic response associated with hexadidine-based GLP-1 receptor agonist. We talk about the common side effect, nausea, vomiting, diarrhea, and we said that they are mild, transient, and rarely lead to discontinuation of this medication, but in some patients, they are significant enough to lead to discontinuation of this agent. But what's good about these side effect, nausea, vomiting, diarrhea, they are transient and mild. Okay, let's talk about more serious side effect. The acute pancreatitis. Initially, the FDA state that there might be causal relation between GLP-1 receptor agonist and acute pancreatitis. Then after these trials, which are actually cardiovascular outcome trials, included in the secondary outcome, the incidence of acute pancreatitis, they state, the FDA, that a causal relationship couldn't be established between GLP-1 receptor agonist and acute pancreatitis. But they advise to exercise caution in patients with a previous history of acute pancreatitis, not to be initiated this agent. Okay. Although in this cardiovascular outcome trial, there was no risk of increased acute pancreatitis with GLP-1 receptor agonist. What about pancreatic cancer? Again, these data driven from the cardiovascular outcome trials showing no signals for increase of pancreatic cancer. But this is not reassuring data-wise, that because this is cardiovascular outcome trial, it's calculated and powered to detect cardiovascular outcome, not to detect pancreatic cancer or malignancy. You know, the late onset of this malignancy, which might lead to the lead time bias. Okay. We talk about the common GI side effect. We talk about the acute pancreatitis. And another common statistically significant GI side effect with GLP-1 receptor agonist, the cholelithiasis. It's associated with 30% relative risk increase of cholelithiasis, and this is statistically significant. What about the microvascular outcome? If you would see the cardiovascular outcome trial, you would see here there is a reduction, relative risk reduction of composite of microvascular composite outcome. This is mainly driven by the renal outcome, specifically the decline of albuminuria. But the eye outcome, or the diabetic retinopathy, it's increased by 24% with the dulaglutide, although it's not statistically significant. But with semaglutide, the injectable weekly semaglutide, there was 76 relative risk increase of diabetic retinopathy, which was statistically significant, as you see here. And if you would calculate it, the number needed to harm over almost 104 weeks is 77. So you need to treat 77 people with type 2 diabetes with weekly semaglutide to have either vitreous hemorrhage or blindness, or intervention lead to photocoagulation, which is significant. That's why it's recommended people with proliferative diabetic retinopathy, vitreous hemorrhage, or myelopathy not to be initiated on GLP-1 receptor agonist, specifically the semaglutide, the injectable one. And to close, if you started in other people with type 2 diabetes, to close, to monitor diabetic retinopathy closely. Okay, this is about the side effect, the microvascular outcome and the GI side effect. Let's talk about the cardiovascular outcome. The three cardiovascular beneficial GLP-1, the liraglutide, the dulaglutide, and the semaglutide once weekly, not the oral one. The oral one failed to show cardiovascular benefit. It was a neutral, okay? So the injectable semaglutide and the dulaglutide and the liraglutide associated with positive reduction of what's called MACE, major adverse cardiovascular event. The only one associated with decreasing cardiovascular death, the liraglutide, the one associated with decreasing relative risk of stroke, the dulaglutide and the semaglutide. About heart failure hospitalization, it was not significant. about the CKD progression, it was a significant relative risk reduction, mainly the albuminuria, not the GFR decline. The other three which are not associated with cardiovascular benefit, the lixisenatide, the exenidine 4-base, and the exenatide once weekly. But those should be viewed as a neutral, not negative trial. Why neutral? Let's see the Excel, which testing the exenatide once weekly. You see here the cardiovascular outcome trials assigned or conducted, which was called comparing the exenatide to the placebo plus standard of care. Standard of care, which means that obviously those who assigned to exenatide, they will have a reduction in A1C. Those assigned to placebo plus standard of care, their A1C gonna rise. So you would, per protocol, per standard of care, you will add other agent other than GLP-1 receptor, like the DB4, like the sulfonylurea, and one of them, the SGLT2 inhibitor. You see here, 9.4% received SGLT2 inhibitor, which might be one of the explanation why the cardiovascular effect was attenuated in those assigned to exenatide. Could be, this is one explanation. This is the most...
If you can conclude in 5 minutes.
Yes. Okay, the most recent cardiovascular outcome trial showing the positive effect of the three agents, the liraglutide, semaglutide, and dulaglutide. Why is that? There are proposed mechanism why some of the GLP-1 receptor agonists, they have cardiovascular benefits. One of it, they affect the endothelial function and the myocardial contractility. This is from one meta-analysis. Approximately GLP-1 associated with 2 to 4 systolic blood pressure reduction, but they are associated with increased heart rate, 2 to 4, and some agents could be up to 7 to 9 beats per minute. Okay, and this leads us to questioning the heart failure association. We know that DPP4, which carries the same mechanism, they have some signals of increasing heart failure. Okay, with savertemy, which examining the saxagliptin, and in observational study even with the sitagliptin. Okay, so the GLP-1 receptor agonists, which carry the same mechanism, specifically the liraglutide, in people with reduced ejection fraction, in 300 patients in randomized trial, they increase the death and hospitalization of heart failure by 30%, although it was not statistically significant because of the small sample size. This is another randomized control trial conducted in 241, and if you would calculate the number needed to harm in people with advanced heart failure, ejection fraction less than 45%, liraglutide associated with increased risk of hazard ratio 3.9, and the number needed to harm 13 patients. You need to treat 13 patients to have one additional serious cardiac event, cardiac death, or supraventricular tachycardia, or AFib. That's why the CVOT trials, including the GLP-1 receptor agonists, they exclude those with heart failure class 4. And if you would look at the percentage of those who having heart failure from these large CVOT trials, they range from 9% to 24% of the total study subjects. Okay. So there are CVOT limitation, lacking of generalizability, especially if you are talking about primary care. The cardiovascular benefit, which shows mainly by these agents in people with established cardiovascular disease and advanced status, which might be not reflecting the primary care study population. Here, the treatment algorithm, the ESC, they go in extreme and they advise starting right away GLP-1 or SGLT2 inhibitor with type 2 diabetes drug naive, even without going with metformin, and this is in consensus with the ADA. The ADA is still recommending the metformin to be the first line agent, and my colleague Dr. Amar will talk about the ADA and our national Saudi guidelines of drug algorithm. Thank you.
Thank you very much, Dr. Saleh. Very interesting data. If I may summarize, looks interesting, promising, like once weekly weight reduction or at least no weight gain, good for the heart. Be careful with the vitreous hemorrhage. Be careful with the CHF. Some GI side effect that to consider. You get us excited, Dr. Saleh, about it. I want to go back to Dr. Waleed. Dr. Waleed, let's go back to the basics. Let's try to make sense of the GLBs after excitement اللي دخلنا فيها الدكتور صالح. So, Dr. Waleed, let's go back to the basics. Try to learn what are these GLBs. The floor is yours, Doctor.
Excellent. So just give me a second, just so I can share the screen. Is this screen clear for you or not?
لا دكتور لسه ما احنا شايفين السكرين حقتك.
Okay, just a second, sorry. Okay, طيب. Is it clear now?
Yes, we can see it now.
Okay. طيب, Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Saleh, for a very nice presentation. I wish this lecture to be in the beginning so we can have an introduction to the GLP. And the first time I heard about GLP was about 15 years ago when one of the actually doctor from Mexico, he presented to us during my training in 2005. He presented about this glucagon-like peptide, this GLP, as a unique product that extracted from the Mexican lizard, and that one used for a treatment for diabetes. The first time I heard about this, it was for me very strange when I was fellow, and I wasn't expecting that after all of these years, that this medication is really will be one of the really very strong medication in the guideline for the past now 3 years, and being in the top medication, especially in the from cardiovascular point of view. So what I would like to talk about this GLP, what is it? It's very important to know the basics of it. We'd like to know what the physiology of GLP, what the mechanism of action, what are the types of GLP that we know, what are the pharmacodynamics and kinetics. So when you look actually for incretin effect, one of the things, GLP is a hormone. And as you know, this hormone is extracted from the, getting from the intestine. And when they did this simple study, they look at the plasma insulin response to oral and intravenous glucose. Very, very interesting study. In the left diagram, you can see that they give the patient an oral glucose with the green line and with a blue line, and they give intravenous glucose for the same patient, the one with the green line. So one patient given oral glucose and the other one given intravenous glucose. They would like from this study to know what is the effect of the GI in the controlling the blood sugar and the insulin response to the glucose. So in normal non-diabetic patient, what they found actually very interesting, that when you give the oral glucose, you have more insulin response compared to patient if you receive an intravenous glucose. So this means that there is some important molecule that is the GLP in the intestine. It play an important role in the insulin response to any meal or glucose. So in diabetic patient, this actually a response of the GLP is blunted. So you can see here in this diagram that in oral glucose and intravenous glucose, again, the oral glucose is the white one, and the orange one is the intravenous glucose. And you can see very clearly the difference between the response between the oral and the intravenous is because of the incretin effect, which available in the GI tract. So a phenomenon whereby a glucose load delivered orally, it produces a much greater insulin secretion than the same glucose load administered intravenously, indicating that the effect of the incretin, and from that part, the incretin come to the idea why we don't just use this medication to synergistically affecting the insulin and have more effect on the glucose response. So incretin effect, actually interesting in type 2 diabetes. Incretin effect, that effect is blunted in type 2 diabetes. If you compare the one in the left side, the healthy, and compare to the type 2 diabetes in the right side, you can see this incretin effect is actually blunted. So then the idea came up, why we just give an incretin-like effect or GLP to a patient with type 2 diabetes, that might magnify the effect of the insulin response and have better glucose response. So if you look for here, actually again, that the GLP-1 enhance the first phase insulin response in patient with type 2 diabetes. So again, you can see that if you give the GLP-1, actually, it actually, as you see in the right side, it showed that how it actually magnified the response of the insulin response when we given to a patient with type 2 diabetes, and this was studied, and from that, the story of the GLP started. So when you look to the GLP and what happened when we eat, for example, you eat a burger, it go to your actually intestine, and then your stomach and your intestine, and then this will result in release of active gut incretin hormone, or the active GLP and GIP. And that active GLP hormone, it's called the incretin effect. So what does it show? It actually causes glucose-dependent insulin secretion from beta cells, and that decreases the glucose uptake by the muscles. And also, it affects on directly also as a glucose-dependent effect, that it decreases the glucagon secretions from the alpha cells, and that result in hepatic glucose productions by the liver. With these two mechanisms, it results in reducing the glucose, and it results in improving of the glucose level. So the GLP actually have a multifactorial effect. It's that pharmacological effect. It's effect on the level of the pancreas. So it basically result in improved beta cells function. So it also increases the enzyme biosynthesis. So that is really important. It affects at the level of the liver. So it decreases the hepatic glucose productions, the improved hepatic insulin sensitivity. It decreases the de novo lipogenesis. It decreases the steatosis, and it decreases lipotoxicity at the level of the center brain. It decreases the body weight and decreases the food intake and increase the satiety. So it actually have a multi-effect. It affects on the beta cells of the pancreas by decreasing glucagon and secretions. It affects the GI tract by decreasing the gastric emptying, that's why it reduces weight. It also increases the nitrates at the level of the kidneys. It improves the insulin sensitivity at the level of the muscles. The GLP receptors is available actually in different part of the body. So the question is the GLP therapies, now what they did, they synthesize, and pharmaceutical companies, they synthesize a molecule, different molecule from this GLP to do the same action. But these molecules are not the same. They are different. Actually, one, it could be either long molecule, long acting, or versus short acting, some of this GLP. So that's why some of them is daily or some of them weekly. Also, some of these molecules are large molecules, some are smaller molecules. Also, we have GLP-1 base versus exenidine base. That is a human GLP or not. So the GLP-1 receptor agonist is usually subcutaneously administered, and it's there's a human GLP-1 backbone where it could be weekly, and what is available is the tapsoglutide. We have aliglutide, dulaglutide or Trulicity, semaglutide or the Ozempic. And then the once daily, which is the liraglutide or Victoza. And in the other side, the exenidine backbone, we have the weekly, which is the Bydureon or exenatide once weekly, or the BID like the exenatide or lexenatide available in the market of Selequa, which combined with glargine as a combo therapy. So if you look for the GLP molecule, it varies in molecular structures, which is available in the market. You can see we have the exenatide, we have lexenatide, liraglutide, semaglutide, dulaglutide, aliglutide are different actually in their biochemicals, polymers and peptides are different, and that actually define its half-life and pharmacokinetics. The smallest molecule is dulaglutide, exenatide, lexenatide, semaglutide. However, the bigger one is the dulaglutide, and aliglutide is bigger molecular size. That is reflected on the pharmacokinetic profile of the approved GLP also. So, as mentioned by Dr. Saleh, we have a couple of these GLP. So, for example, from the top, we have exenatide, BID, available in the market as a combo therapy. We have, it's called Byetta, or available as a combo with the glargine, like what is called Selequa. So the half-life is 2.4 hours. Tmax is 0.6 hours. We have the liraglutide with the half-life of 13 hours and a Tmax of 8 to 12 hours. And then we have dulaglutide, which is 4 days as a half-life, and then the Tmax in 24 to 48 hours, which is Trulicity. And then we have the Byetta, or Bydureon, sorry, exenatide, 7 to 14 days as a half-life, and 6 to 7 weeks for Tmax. And finally, the Ozempic or semaglutide once weekly, that the half-life is 7 days, and the Tmax is 1 to 3 days. So these different, that's why some of these molecules given daily, some given weekly, because it varies in their pharmacokinetics. So at the end, actually, what I would like is to mention that we're lucky to have this different kind of GLP. This GLP is a unique product that it stimulates the glucose-dependent insulin secretions. It affects the glucagon secretion from alpha cells. It works on different GLP receptors in the brain. It has improvement in decreased satiety and also decreased appetite, and that improve on the weight reductions. The presence of GLP on different organs, including the heart and the kidneys, give the unique effect of this medication on the cardiovascular outcome trial, as mentioned by Dr. Saleh, that these GLP, including specifically liraglutide, Victoza, semaglutide, as we learned from LEADER trial and SUSTAIN trial, and the Trulicity, as we learned from DREAM and REWIND trial, it's indicating how these molecules important in reducing cardiovascular mortality and morbidity. All the use can be used in patients with secondary preventions, and Trulicity used in both primary and secondary prevention in cardiovascular, which is the most common cause of death in those patients. So, and I think somebody will talk, Dr. Omar maybe, will talk about where the GLP based in the guideline. Remember, this medication now is well-known medication used especially for patients with established cardiovascular disease and in patients with a very high risk for cardiovascular disease. Those patients, we have to actually start them on these medication. selecting the category of those patients with obesity, high risk patient, nephropathy. So probably is an excellent candidate, and it works synergistically with other group of medication, SGL2 and metformin and other group medication. In my practice for the past 3-4 years, I started an increase in prescribing more and more of GLP because of its unique effect of these medication and its high benefit on patient A1C, patient cardiovascular, the weight, also the fatty liver, and the sleep apnea. So a lot actually of non-glycemic control and non-glycemic effect. Ladies and gentlemen, thank you very much for nice listening.
Thank you very much, Dr. Walid. A very informative session on the basics and how to make sense of the GLBs. Thank you very much for the informative session. Now, I want to invite to the stage Dr. Umar Al-Amoush, who is a practicing family physician at Johns Hopkins Aramco Healthcare, to present to us our national diabetes guideline. As you know, the Saudi Society of Family and Community Medicine, through close collaboration with the Council of Cooperative Health Insurance, adopted certain of protocol and guidelines to help care for our diabetic patient, and that protocol was one of 20 already released guidelines by the CCHI. And I want to take this opportunity to welcome Dr. Umar. As a practicing physician, Dr. Umar, tell us where the GLB lies in the guidelines and in your hand as a frontline clinician. We'd love to hear from you. Abu Hamza.
أسعد الله مساءكم. السلام عليكم ورحمة الله وبركاته. Thank you very much, Dr. Saleh, Dr. Walid, for a great presentation. Now the real deal. We have heard about the GLP. You got us excited, and at this instance, I will be your advocate as a primary care physician and frontliner. Most of us who treat diabetes are not endocrinologists or primary care physicians with interest in diabetes. We have 101 other things to do, and it's very difficult for us to grasp all the knowledge that has been presented by my colleagues. Hence, this guideline was developed. And if you can see it very well, I would like to highlight a few things about this guideline. This guideline is probably the most useful, user-friendly, and usable guideline. It's not a tool. It's a tool. It's a tool that you can use every day in your practice. It's not the gadget that you put on the shelf. And if you got yourself excited about the GLP and it is staying on the shelves of the pharmacist and you are not using it, then it's as useless as not being invented. So this guideline basically advise on the clinical practice of using therapies in diabetes. And the first highlight is, can you see my cursor? Yeah, comprehensive lifestyle. And I would like to introduce comprehensive lifestyle as medication number 1. And every time you revise what your patient is taking, consider comprehensive lifestyle as a medication that if the patient is not doing, that the patient is not compliant with. The other highlight about this guideline is it simply remind everyone with the diagnosis of diabetes, and the most important thing is the targets of diabetes. We rarely talk to our patients with targets and establish shared agendas with them. And actually, if you look at all the treatment and escalation of treatment for diabetes is based on establishing targets of treatment. The other thing that is hidden is if if the target of your HbA1c is not achieved, and there's no response after 6 months of treatment, that's the time when you need to consider stopping using that agent. And I will come to that in a bit. So this guideline is the national guideline. It is in accordance with the ADA. It's not far away from the one used in Europe. And in this guideline, every patient who present with the normal presentation of type 2 diabetes to your clinic should be offered comprehensive lifestyle advice and started on metformin. I'm pretty sure at this stage, all of us know how to escalate and titrate up metformin. The question is, what comes after metformin? And hence is the major change. And all the benefits that were mentioned by my colleagues. If you identify your patient as having high risk of cardiovascular disease or established cardiovascular disease or at risk of CKD, then this is the time when you to consider GLP-1 receptors. On the other side of the guideline, you can see the table 1, which gives you a description of the names and side effects and the benefits. And these are the benefits or the patient-specific factors that will help you decide which agent to use. So if life is kind to you and the patient come to you and you make the diagnosis and you start the metformin and the patient come back in 3 months and you want to escalate the treatment because the target is not being achieved, you identify your patient as having a cardiovascular risk or established cardiovascular disease problems, this is the time when you consider GLP-1 or an SGLT2 inhibitor if there is heart failure. The third agent to start after this, again, you go ahead and you review the whole history and you go through the comprehensive lifestyle, you check the compliance, and if you use a GLP-1 in the first as a second line, you choose a third line from the other list based on the patient factors listed in table 2. And you go on and escalate the treatment and titrate it up until you reach insulin, and you start your insulin, the basal insulin, and you go up to the adding bolus insulin. So GLP in this instance comes as the second agent or the third agent if you consider lifestyle changes as an agent, and it's straight away after metformin in patients who have these characteristics. The 2 or 3 things I would like to highlight is this is not reflected in true practice. And the reason is life doesn't send us patients like this. We end up seeing patients who are already on 3 or 4 medications. None of them are GLP. And it's very difficult then for primary care physicians to stop medications, to de-prescribe. And I find this is the biggest challenge for using new agents when it comes to diabetes. The classical story will be the patient started with metformin, then sulfonylurea, then the pioglitazone came, someone stuck the patient on Actos, the patient was fine, now they developed heart failure or heart problems due to aggravated by the Actos. Someone started them on SGLT inhibitor, then they come to you, the target is not achieved, and you look at the guideline and how to start a 4th or 5th agent. And we see people on 5 agents these days, unfortunately. I think the rule is go back to the first medication, second medication, lifestyle changes, recheck your patient and choose and get yourself familiar with what is available for you. And don't hesitate to stop medications, especially if you can establish that these medications are not working. At the bottom of this guideline is a simple, easy way to start patients on insulin. The second is all the agents or most of the agents that are available at the time of publication in Saudi, highlighting their efficacy, their effect on the common patient factors like weight, hypoglycemia, cardiovascular risk, and kidney disease, and highlighting the side effects as well. and the injectables are apart from the GLP, the insulin injectables are at the bottom, and it's too difficult to include all the combination treatments. So we left that for the individual practitioner to look it up. That's all from my side, Dr. Hadi.
Thank you very much, Dr. Umar. It's very interesting. Like we've been through nationally adopted guidelines, and through the great support from the CCHI, collaboration with the Saudi Society of Family and Community Medicine, the whole message was to encourage the frontliners, the primary care physician, to start the best available medicine for their patient according to the last evidence. And as mentioned by Dr. Umar, we will face on daily basis patient on 3, 4, 5 medication and not working, and yet for some reason GLP is not one of them. If you go to this simple guideline, which again we'll share it through the society website, it's on the CCHI website, we're going to share it through the FM Hub, and we in the society, we're going to work with our colleague and expert, just like this evening, to even conduct workshop to make people comfortable on how to prescribe and apply the best available evidence to our patient. So I want to take this opportunity to send an open invitation to all those who are interested to be competent in managing patients with diabetes. Please come forward. We'll work with you. We'll work together to provide you with the resources that will enable you to prescribe the best available evidence. Dr. Walid, I want to come back to you. I like listening to you, listening to Dr. Saleh, going through the guideline that we have in hand. Why this intervention medication is not being adopted by us in the front line? What is it that we are not doing or doing wrong? You as the subject matter expert endocrinologist, what feedback you want to give me as a frontline practitioner?
Well, one thing we should know about GLP is actually is costly medication. It's an expensive one. So it's not actually available in all institutions. So a lot of primary care center, they don't have the GLP, and it's maybe in big hospitals is only available, like in the university hospitals or some of the MOH hospitals. So that's one thing, really one of the obstacles that face. And I think the decision maker in Ministry of Health need actually to recognize that there is a big change happen in the guideline for the past 3 years, that these medications should be implemented. And this guideline should be for sake of patients actually, and for their health. Most of the medication available in the primary care is either self-medication, the DPP-4 inhibitors, the TZDs, insulin, but for this GLP, because it's expensive, so that's the problem. Even in the big hospitals, some of these medications restricted to the endocrinologist to be written because it's expensive. But the decision maker need to know about this lecture, about this presentation, how this group is very useful for patients. And actually, I see a lot of my patients, they really do very well, and they're happy about the progressions of their diabetes, their A1C, their weight, and they're quite happy. But they have problem if they cannot afford it. So ممكن هذا يكون هو السبب. I think this is one of the main problem why it's not actually used a lot in primary care physicians a lot. But there's I think it's a simple used. It doesn't need a lot of instructions. I mean, it's very, very easy. Main side effect is the GI side effect. No risk of hypoglycemia. Need a good contact with your patient, reassurance for this. And I think if it is available for them, they will not hesitate to start with it.
Thank you, Dr. Walid. Dr. Saleh, you work for the Ministry of Health. You are the subject matter expert among your colleague of primary care, and refer to you because you are diabetologist as well. tell us about the availability, the concern of the GLP or the cost. How would you? What's your intake on the availability slash cost as the main stopper from providing this? I would say one of the best intervention for diabetics to our patient.
Okay, well, when we look to the cost, also we should look to the cost effectiveness. Okay, we know that people in the kingdom, there are many people affected with diabetes. We are among the highest countries which having a prevalence of type 2 diabetes. Okay, so if we look to the cost effectiveness, and if we put in our mind that the legacy effect, okay, the earlier you control your patient, okay, the better outcome. So we shouldn't wait the patient till he got the criteria to be referred to the secondary or tertiary with the established complication, then we should intervene. We should interfere from the frontliner, the first level of primary care, as much as we can invest on those patients to get them to the tighter control, the better outcome. And here will be the cost effectiveness. Another issue about this medication, it might be not, we need a large studies in primary care population, because you know these GLP-1 receptor agonists, most of the CVOT trials conducted in advanced people in hospital settings, people with established cardiovascular disease. So it might be not representative for the primary care patients.
Dr. Umar, I was talking to you earlier, and as a frontline physician, when was the last time you started patient on GLP from your own practice?
2 days ago.
Can you share with us what was that patient?
حقيقة أبو عبد الملك, I feel there is زحمة in the market. The patients receive so many messages. And we as physicians, sometimes we, out of desperation, we start our patients on whatever is new or available to us. And we are partly to blame ourselves. The third thing I think is that you will find all kinds of studies, but you will never find the kind of study that will tell you when to stop the medication. So once you stick someone on a medication, that's it. It goes on forever. And this is probably the biggest challenge. Our patients are saturated with 3 or 4 medications, and we assume that patients don't want injections. And we assume that it's not okay to offer someone who's been diagnosed 6 months ago with type 2 diabetes an injection as the second line of treatment. And we do a lot of assumptions. The good thing about the GLP is probably the only injection that has shaped our beliefs in the way that patients know about it and they want it. And the patient, I didn't know that we have semaglutide in our institution. I thought it's the glutide, and he came asking for it. And when I did the review of his medication, I had to stop 2 medications. It was on 4 oral different types of oral hypoglycemic agents. I had to warn him that his blood sugar may go up. Not every single patient will respond to the GLP, and this is a fact we have to address. And I always tell my patients that we will review this in 6 months and probably stop it if it is not working. And when I prescribed the medication, the pharmacy called me and said it's a deleted item and we have semaglutide, and started the patient with semaglutide. To be honest, I was not the initiating. It was not initiated through me, and coming across patients like this person who's on 4 medications and his hemoglobin A1C was 8.9. I don't think any guidelines will tell you what to do exactly. You have to just remember that these guidelines are there. The patient was treated by someone before you. At that time, that patient is a different patient from today. That patient, when he was treated 10 years ago, did not have cardiovascular disease, did not have the medication tried on them. They health beliefs were different. Their resistance to start injections was different. So yes, it's the same name of the patient, but the patient I'm dealing with today is very different from the patient that I have myself dealt with 3 or 6 months ago. Hence, I think this is probably one of the guidelines, the very small number of guidelines like this, that you always need to go from the start, starting from lifestyle modification, and go all through the guideline again every time you see the patient.
Dr. Waleed, let's say that I referred my patient to you as a primary care physician who is on the metformin, sulfonylurea, another oral medication, and on insulin, and yet his A1C is 9+. What to do with that patient regarding the GLP? Is it too late for him? Is it stop everything, go GLP? What's your suggested approach to such patient, which is quite common, by the way, in our practice?
Yes. Yes, this is a very important question. And this is the usual referral that we got from our colleague from primary care. One of the important things actually is using insulin and sulfa have a high risk for hypoglycemia and high risk actually for weight gain. And with all of that, actually, it results in defensive eating. The patient actually start to defend from worry about hypoglycemia. So they start, gaining weight, and their A1C still is high. So the GLP actually is really, really very excellent in those patients who is having, obesity, high BMI, have fatty liver, they struggle with hypoglycemia. So that's the beauty of adding the GLP. Now, such case like that, the one you mentioned, you need first to evaluate your patient, looking for all the features. For example, in any high-risk features of cardiovascular, check the renal, check for the BMI, check if there's GI side effect, the patient have reflux, have IBS, and then you try to ask him to check his blood sugar at home and see his eating habit. And after evaluating his status, then one thing we can introduce is probably the SGLT2 inhibitors, the GLP, and metformin. These 3 medications can be used either as a combo therapy, like there's a combo between SGLT2 and metformin as add-on therapy, and then you introduce the GLP. I don't actually, my using of sulfonylurea reduced markedly over the past 3-4 years. I don't recall I used a lot of sulfonylurea for the past 4 years, a lot. So one of the medication might stop is the sulfa medication and keep him, for example, on basal insulin and add GLP, and probably introduce the metformin and SGLT2 inhibitors. We don't only treating only the numbers and A1C. We're not treating only the weight. We also want to add medication that has a benefit on the patient cardiovascular as well as the renal. Because if I have a medication that reduces cardiovascular mortality, morbidity, as well as nephropathy, so this is a good medication that I need to use. So that's what I usually do. I stop using sulfa, I reduce the insulin, basal insulin, and I introduce the GLP with metformin and SGLT2 inhibitors in a way that I titrate toward normal fasting blood sugar less than 120 and normal postprandial less than 180, and watching the GI side effects for the initiation process.
Thank you, Dr. Waleed. So I want to summarize the Dr. Waleed mentioned. So my patient that I sent him with the bag full of oral medication, the first one to go will be the sulfonylurea. It will be stopped, and then he will look to optimize the SGLT2, SGLP1, plus looking to the insulin. Dr. Saleh, as a primary care physician, forget you being a diabetologist. Is sulfonylurea still in your prescription bag?
Okay, I'm still a primary care provider, and we are working in the front lines. Okay, so as we say that diabetes actually is a primary care disease. Okay, and we are conveying this message that we should be our best effort to control these people before they got established complication, before the game is over. So About sulfonylurea, there are controversy. There are some studies suggesting and linking sulfonylurea with the cardiovascular risk. And this is mainly for the first generation sulfonylurea. The other things about the glibenclamide, I would give a clear message: shouldn't be given to elderly people and shouldn't be given to people with estimated GFR less than 60. I want to point an important, highlight an important things about usually in the guidelines, because it's mainly driven from US guidelines. You would say that compared to glibenclamide, the glimepiride associated with less risk of hypoglycemia. Okay, why is that? Because simply they don't have a glycoside. We have the glycoside, and it's much safer and less risk of hypoglycemia compared to glimepiride. Some studies linking glimepiride with heart disease. With the long decades use of sulfonylurea, it's still in the list, and you would go patient-centered approach. It doesn't have GI side effect, the sulfonylurea, and if you use for example, the glycoside, it's having less risk of hypoglycemia, given that the patient doesn't have impaired estimated GFR. We should also consider the cost. You could prescribe it, considering the cost and considering long-term data about sulfonylurea. Remember, GLP-1 receptor agonist is still new. It's only 15 years. We don't have long-term data. There is you have actually also to counsel your patient. You would go patient-centered approach. Even if you would go with GLP-1 receptor agonist, patient preferring not to gain weight or preferring to lose weight, and he is excited about cardiovascular benefit, I would explain the cardiovascular benefit might not be applicable to you. Most of the trials, it's for secondary prevention, except the dulaglutide. Okay, this is one thing. Another things we have to ask about history of medullary thyroid cancer, personal or family history of medullary thyroid cancer or men type 2, and personal history of acute or chronic or previous episode of pancreatitis, and history of gallstones, history of bypass osgastrectomy, history of gastroparesis, and of course, for all your people with type 2 diabetes, you are doing annual fundoscopic exam. People with proliferative retinopathy, people with vitreous hemorrhage, people with micropathy should be excluded. Okay, and you should counsel your patient about the black box warning about this possible, not yet proven side effect. We are waiting, it's a matter of time. The cardiovascular outcome trials, although they showed that there is no increased risk of cancer, no single case in a human reported with medullary thyroid cancer, but this is a rare disease, and the latent onset should be decades and years, so we don't know about long-term safety about this medication. I think these all should be explained to our patient, and we should go patient-centered, and the patient would choose. He would be motivated, and he's a partner and should be involved in the decision. Would he go with sulfonylurea? Would he? Some of my patients, when I counseled them, they told me, no, I would go with natural. After metformin, give me insulin. It's natural one, I would go with natural. So it's a patient-centered. All these agents are, as Dr. Omar, the national guidelines and in the ADA, depends on the patient factors, combining to cardiovascular benefit or CKD or presence of heart failure or cost issue or weight loss. So we will go patient-centered.
Dr. Hadi, if you allow me, just Dr. Saleh, allow me just a second, please. Just I wanted to mention about, talk about medullary thyroid cancer actually in GLP. Yes, as Dr. Saleh mentioned, although it's actually extremely rare. This is only reported in rats, as mentioned, but never reported in human being. The GLP receptors is not there in the C cells in the thyroid in the human being. So we have known GLP since in the Saudi market since 2014 till now. there's no significant, actually, any thing that reported with GLP that worthy. And for that reason, actually, the FDA approved the Victoza or liraglutide for kids above age of 10, which is that this group is sensitive. And even Saxenda or the for weight reduction approved with a higher dose GLP for age above 12, 3 months ago, indicating how this medication carry more safety. And I think it's not more a causal relationship. It's kind of association sometimes can happen. Also, my patient, if I tell about cancers, Actos has reported possible bladder cancer. At one time, Glargine Lantus also was possible linked to cancer. Then you mentioned about DPP-4 inhibitor and GLP about pancreatic cancer. So all of this story about cancers comes and goes. But I think we need to be careful discussing, this maybe briefly, but we need to reassure our patient. The most common cause of death in patient with diabetes is cardiovascular, is myocardial infarctions, is strokes. This is what killed my patient, not cancers. Cancers is not from the medication, it may be from environmental factor, but that's what I would like to reduce in those patients. And one thing is we need to think beyond the A1C in any patient with diabetes. A1C now is SGLT2 inhibitor, for example, like Jardiance or Forxiga. It reduces the A1C mildly, but have a significant effect on heart failure, CKD, and which indicates there's some non-glycemic effect. So now I think we should think beyond the A1C. I can improve the A1C of patients with diabetes within 1 week by giving sulfa or giving insulin. But the question is not to actually improve the A1C, is what medication add for that patient that have multi-effect at different level and in long-term effect in those patients. So one thing about sulfa is really, I use Dimecron, I still use it in some patients where you struggle, and it works very well. It's cheap, is again, old as gold, and is safe, have good safety profile. So still we use it, but I think with the new guideline and new studies coming, it's not new anymore. Actually, now almost we have good data for 6 years now, started from 2015. Now there's a quick evolution coming for in the ADA and ASAD, and our look should to be different. Do you know that if A1C is normal of 6.5, let's say, and patient on metformin, and he had myocardial infarction, you must actually introduce SGLT2 inhibitor in those patients, even with A1C normal. So this indicating that we are thinking beyond the glycemic control in those patients. Do you know that if patient high risk, metformin is not anymore a first-line therapy. SGLT2 inhibitors or GLP is the first line in those patients who are high risk, not metformin anymore. Where metformin 100 years was one of the best and the king. But in these particular things now, the guideline is changing now. And I think this is the idea which we need to deliver to our colleagues from primary care, that it should be available in their centers. They should use it. They should choose the proper patient, as Dr. Saleh mentioned, proper patient who might benefit from this. If he's my father or my brother, I would like to use the thing that give him all the best for this. So this is my just a comment. Sorry for interruption.
Thank you, Dr. Walid. Thank you, Dr. Saleh. So let me just put the things together. So the sulfonylurea that is the comfort zone of every single frontliner maybe not should be considered anymore, and we should go beyond the A1C, and just like what Dr. Saleh mentioned, look to our patient characteristics and build on what Dr. Walid said, like let's go beyond the number of the A1C, look to the whole benefit. The good things عندنا هنا in the country, the cost may be actually the main game changer, and for the majority, I would say, of our patient. Either they are provided care by the Ministry of Health, or they are insured patient, and the insurance would follow whatever endorsed guidelines. So I think we as a provider need to go beyond the immediate cause and look to the individual patient, what will work best for the patient, and try to advocate for our patient. So the This intervention will be made available to us if we advocate for our patient. If we did not advocate for our patient, sulfonylurea will continue with them, the only available medication. Dr. Umar, I know you like the checklist. So there's so much mention between Dr. Saleh, Dr. Walid. If I ask you, give us your checklist before you start patient on GLP. What are things that you will definitely put in the checklist and things that you may or may not go in deep? As if I'm busy, I have like 10 minutes per patient, so I don't have all the time available. So what will be your checklist, high priority checklist, as a frontline clinician?
Great question, Abu Abdul Malik. My checklist is the national guidelines, which exactly combine what Dr. Saleh and Dr. Walid said. So it says in this box, this GLT should be introduced regardless of A1C reading. So if it is normalized, you still need to introduce this GLT because of the other benefits based on box number 1, which has the patient characteristics. So my checklist, well, traditionally I will go over the A1C. If it is controlled, I'm happy with the patient. I will look at any changes from the last visit, and it's quite easy. They are the same. The cardiovascular, kidney function, blood pressure, weight, and obesity. And knowing what is available in my institution, the GLP are among the easiest to remember of their problems. So microvascular disease, as Dr. Salah said, gallbladder stone, I think it's a major one. You don't want someone to end up with pancreatitis, history of pancreatitis, and history of gallbladder stones. And if you have a fish memory like myself, you just go over box number 1, and it's all there for you, including the medullary cell carcinoma and the common side effects of GI. Now, the main thing is to differentiate between cardiovascular risk assessment, which is the atherosclerotic part of things, and heart failure. So GLP-1 inhibitors, up to my knowledge, they are neutral in heart failure and beneficial in those with established cardiovascular disease. Hence, they may not benefit every single patient primary care. So GLT is a very good option if A1C is near, is around 1 or 1.5 above the target. If that is more and the patient is really motivated to lose weight, I started to think of my patients the same way I deal with patients post-MI. So you will ask someone, do you smoke, if they had an MI? You won't overlook this comorbidity. And for a reason or another, we started to overlook obesity and diabetes. And he's diabetic, he has to be overweight or obese. GLP is an excellent treatment for obesity, and improving obesity will improve all systems, including the hyperglycemic control in the body. So my checklist about numeric is the patient preference for sure, and their A1C level, and the cardiovascular risk assessment, their weight, and their kidney function. And the absence of side effects, which are mainly microvascular disease, history of pancreatitis, and gallbladder disease.
Thank you very much. I just want to highly encourage our colleagues out there to please grab that, like one page on 2 sides, the guidelines, walk through it. It's literally meant for a very busy practitioner at the front line. It summarizes all what's mentioned by our expert colleague here. Before we go to the next, Dr. Walid, you got a patient who is pre-diabetic and a little bit overweight. Would you put him on GLP?
Okay, well, pre-diabetes, the best things always I go with, as a lifestyle change, the exercise, the diet, this is the usual, what I do for my patient. And we know from the DPP trial, which is Diabetes Prevention Program, a trial, famous trial where they randomize patient to either a placebo, or I mean, lifestyle change, exercise, in addition to metformin. And the metformin, it reduced the pre-diabetes to progress to diabetes over 3 years by about 30%, and the exercise, the lifestyle, by more than about 60% or 58% something. So, but some patients, they cannot do exercise, they are busy schedule, they are a global traveler, they have busy schedule, they can't do much in their diet and their exercise. Those patients, I might offer them a treatment. One of this is metformin. It was well known to be used for those patients. But GLP, if he can afford it and he has obesity, let's say his BMI is high, above 30, or let's say, and he has some, for example, disc problem, osteoarthritis, fatty liver, and he is pre-diabetic, and he had no time or have no ability to much reduce his appetite, then I can use the GLP for them, especially the liraglutide at high dose to reduce his weight, because this not only for his pre-diabetes, for all his fatty liver, sleep apnea, and for osteoarthritis and other things, and his blood pressure. So yes, I use them if they their weight is they struggle with their weight, and they cannot do much exercise, they cannot do much more in their diet, so I use it for them.
Thank you very much. Dr. Saleh, you mentioned about the right selection of the patient, and I personally get a little bit anxious about the vitreous hemorrhage. Now, do I need do retinal exam before starting patient on the GLP, apart from their routine annual? Like somebody who did their annual retina 6 months ago, not told that they have any issue, before the GLP, do I need to do retinal exam for them?
Actually, the only concern which comes from the sustained 6 trials with the semaglutide, the injectable one. The injectable one increased the relative risk by 76, which is statistically significant, and you need to treat those patients. I mentioned the number need to harm, might lead to vitreous hemorrhage and the need for photocoagulation. So those who having in their annual fundoscopic exam, those who having proliferative retinopathy or vitreous hemorrhage or significant myelopathy, they shouldn't be started on semaglutide. So the FDA, and the black or the package insert of semaglutide, they mentioned that it should be monitored closely, and it's part of the routine type 2 diabetic annual fundoscopic exam. But those on their annual exam, they have these conditions, they shouldn't be started on semaglutide. The subsequent Pioneer 6, which tested the oral semaglutide, they already excluded those who's having vitreous hemorrhage or having a proliferative retinopathy. They already excluded from this Pioneer 6 trial for oral semaglutide. And although they are excluded, there was non-significant signal increase of diabetic retinopathy in those receiving oral semaglutide. So this is for the diabetes retinopathy specifically, because what you say in the literature, they are GLP-1, they are reducing the microvascular complication. It's only composite outcome. But if you look to the sub-analysis, the composite mainly driven by the renal outcome, specifically the albuminuria. But for liraglutide, for dulaglutide, there was a relative risk increase of retinopathy, but was not statistically significant. With semaglutide, it was statistically significant, and they issued a warning. Those who's having this condition shouldn't be started the semaglutide specifically, and you should monitor your patient closely.
Can I comment, Dr. Hadi, about, sorry?
Go ahead.
Thank you, Dr. Saleh, a very nice comment. Just I would like to say that from the DCC trial, where they look at the type 1 diabetes, okay, and the conventional versus intensive group, they found that there is an increase in the retinopathy and bleeding actually in those patients in the intensive arm. And that related because of rapid improvement in the A1C in the intensive group, and that well-known fact that fast improvement of the glycemic control and drop of the A1C might precipitate retinopathy. So in that part, having in semaglutide, the FDA and about the GLP, I'm not defending a GLP, but I mentioned that this is exactly what happened in DCC trial with insulin. This is the same thing, and FDA, they attribute that mostly to the improvement in glycemic control, the rapid improvement in glycemic control might causing this worsening of retinopathy. You will do a retinal exam for everybody, for those type 2 diabetes from day one. But I think that contribution for retinopathy, and that from the FDA, if you go to the FDA, they mentioned that most likely because of rapid improvement in the A1C rather than the GLP analog itself. So that's
thank you very much, Dr. Walid. Thank you very much, Dr. Saleh. Now I will give you 2 minutes break. During the break, I will invite our audience to watch a short video about the CCHI that have been mentioned a few times. They are being great support to the primary care of the society in developing national guidelines, and they are one of our greatest partners. So we'll take 2 minute break watching the video.
إنجازات المجلس 2020 انطلاقا من رؤية مجلس الضمان الصحي في أن يكون جهة رائدة عالمية بالوقاية وتعزيز كفاءة الخدمات الصحية لمستفيدي الضمان الصحي التعاوني. وعلى الرغم من التحديات التي مرت بعام 2020 سار المجلس بخطى ثابتة لتنفيذ استراتيجيته بما يتوافق مع رؤية المملكة 2030 من خلال تمكين الفئات المستهدفة من الحصول على التغطية والحماية المتكاملتين، وإطلاق الأدلة الإرشادية الإكلينيكية، وتطوير تطبيق المجلس، وقياس مدى رضا المستفيدين. كما ساهم المجلس بتمكين شركات التأمين ومقدمي الخدمات من رفع مستوى خدماتهم من خلال إطلاق العقد الموحد بين شركات التأمين الصحي ومزودي الخدمة، وتحديد المقابل المالي للمرافق الصحية الحكومية، واعتماد مركز الصلح في مجلس الضمان الصحي التعاوني، ونشاط إدارة دورة الإيرادات واعتماد أول 4 شركات، ومبادرة دعم وتمكين القطاع لمواجهة آثار فيروس كورونا، حيث عملت المبادرة على تعجيل إنهاء المطالبات المتعلقة بعام 2019 وسدادها للحد من تأثير تداعيات فيروس كورونا، وكذلك إنشاء الدليل الإرشادي للعمل عن بعد، تأجيل المقابل المالي للتأهيل والإشراف لشركات التأمين الصحي، تغطية الرعاية المنزلية، تأجيل قيمة الأقساط المستحقة على المنشآت الصغيرة والمتوسطة، تفعيل أنظمة الاتصال الداخلي وبرامج مشاركة الأعمال والإرشادات الأمنية للعمل عن بعد، إنشاء خطة العودة إلى العمل، إعادة صرف الأدوية، وإقامة حملات توعوية وتعريفية للمستفيدين بحقوقهم بعدة لغات. ساهم المجلس أيضا بتحفيز القطاع ليعمل بكفاءة من خلال توحيد الترميز الطبي وإنشاء جائزة التميز لتشجيع ودعم وتطوير قطاع التأمين الصحي الخاص. كما عمل المجلس على تحديث النموذج التشغيلي للمجلس، اعتماد استراتيجية تنمية الموارد والسياسات وإجراءات الحوكمة. كما حصل المجلس على شهادة ملتزمون بالتميز من المؤسسة الأوروبية لإدارة الجودة. أيضا عمل المجلس ضمن خطته الاستمرارية الأعمال والتطوير على دعم التحول الرقمي من خلال إطلاق منصة الحد الأدنى من البيانات، إطلاق البوابة الوطنية الرقمية للتعاملات الصحية التأمينية نفيس، وتم إجراء أكثر من 100,000 عملية للتأكد من صلاحيات الوثائق التأمينية، تأسيس الإدارة التنفيذية للأمن السبراني والمخاطر ورفع مستوى الأمن السبراني، ملتزمون بالاستمرار في تحقيق إنجازاتنا وأهدافنا بأعلى معايير الكفاءة والجودة، ننجز رغم التحديات.
نعود الآن إلى our expert panel, and I would like to welcome to the stage Dr. Hussein Al-Graini. Dr. Hussein is a consultant endocrinologist. He's the section head of endocrinology at Al Musa Specialist Hospital. Dr. Hussein will be talking us through a journey for the role of a new once-weekly GLP in better management of type 2 diabetes. Dr. Hussein, welcome on board. It's an honor to have you with us.
الأدلة الإرشادية الإكلينيكية.
السلام عليكم ورحمة الله.
وقياس مدى
Thank you very much, Dr. Hadi, and the organizers for their kind invitation. It's my pleasure to be here with you this evening. So inshallah, in the next 15-20 minutes or so, we'll be talking about the role of new once-weekly GLP-1 receptor agonist, semaglutide, in the management of type 2 diabetes. So in my slides, I'll be probably summarizing a lot of what was said earlier during this session. So the management of type 2 diabetes has evolved rapidly over the past 10, 15 years or so, and it's become a little bit complicated. So there's a lot of factors that needs to be considered when making a decision with regard to treating patients. So there are factors related to healthcare providers, our patients, and the healthcare system, the available resources that we have. So factors to consider is the target glycemic control. How low do we need to go? How frequently do we need to monitor our patients? Again, the organization of care, what kind of resources and support do we have? What kind of comorbidities our patients have? The need to intensify treatments, their hypoglycemic risks, and many others.
Dr. Hussein, can you share your presentation if you have one?
Yes, I'm sorry. I thought I already shared my slides. I'll try again to stop sharing. Do you see my slides now?
Now, yes, now we're good. Thanks.
Okay. I apologize for the technical problem. So ultimately, our approach to the management of type 2 diabetes has to be a collaborative approach, multidisciplinary approach to the clinical management of type 2 diabetes. Keeping the patient at the center of the care, like our colleagues mentioned earlier. So you, my colleagues in primary care, are the frontliners. You have the most important role when it comes to the management of type 2 diabetes. It's rising at an alarming rate. More than 90% of patients with type 2 diabetes will be seen by you. And this number is likely going to increase over time. So again, keeping in mind the increasing complexity and the management of type 2 diabetes, the different classes available at our disposal, the need to consider hypoglycemia when making decisions, also the choices of different devices available, and then needing to facilitate patient lifestyle changes. So again, you will take most of this part. You have the major role in the management of our patients with type 2 diabetes at the level of primary care. Now, the management of type 2 diabetes has evolved over time. And as mentioned earlier, we've moved from focusing on A1C glycemic control, again, to more cardio-centric, organ-centric approach, if you will, considering the weight of the patient, their cardiovascular risk, and that can be either atherosclerotic cardiovascular disease or heart failure, and also the renal risk as well, based on the data that we have since 2015 with the cardiovascular outcome trials. GLP-1 is a major class that we have now. And again, I'm not going to repeat what my colleagues mentioned earlier, but my focus will be on semaglutide. So the pharmacokinetic profile of semaglutide and the long half-life approaching 1 week makes it very unique and makes it suitable for once weekly dosing. The SUSTAIN clinical program included close to 20,000 patients and 17 different trials, basically evaluating different patients' profiles and comparing semaglutide in different settings, including patients who are drug naive, those on single oral agents, those on multiple agents, and those on insulin. So actually, we've learned a lot about semaglutide, comparing it to different settings, to different patient profiles. Just want to remind you that the dosing system for semaglutide. So initially, we start with 0.25. That's the initiation starting dose, 0.25 milligram once weekly for 1 month. And then we up titrate to 0.5 milligram once weekly. So this can be kept as a maintenance dose if the response we get is adequate. But if we need further reduction in A1C or further reduction in weight, we can always go up to 1 milligram. So we have basically 2 different maintenance doses according to the patient response and their profile. Now, I'll briefly share some of the results of the different, some of the trials in the SUSTAIN program, starting with SUSTAIN-2, which compared semaglutide to DPP-4 inhibitors, represented by sitagliptin. So this is basically showing the change in A1C and the proportion of subjects achieving the target A1C of 7%, less than 7%. So on the left-hand side here, we see comparison of semaglutide at 2 different doses, 0.5 and 1 milligram versus sitagliptin. And again, you see a statistically significant reduction in A1C, more than a triple with the higher dose of semaglutide and more than double with the lower dose. And also in terms of the subjects able to achieve A1C less than 7, which is the target for most of our patients. Again, remarkable difference with semaglutide over sitagliptin. What about the change in body weight? So again, as you might expect with GLP-1, especially a potent GLP-1 like semaglutide, you see a significant weight loss with both doses compared to sitagliptin. And the percentage of patients achieving more than 5% weight loss is more triple with the higher dose of semaglutide and more than double with the lower dose. And we look at 5% specifically because at 5% or more, this is when we see an improvement in the obesity or excess weight related comorbidities, including diabetes, hypertension, sleep apnea, etc. Also, GLP-1 receptor agonists can lower blood pressure. So this is seen in this trial. So the lower dose of semaglutide, 5 points, 5.6 with the higher dose versus 2.4 points with sitagliptin. Moving now to comparing semaglutide with SGLT2 inhibitors, that's also a very important class with an impressive data when it comes to cardiovascular renal protection. So that's in the SUSTAIN, that's based on the SUSTAIN 8 and 9 programs. So if you look at the change in A1C, again, you see with semaglutide a more statistically significant reduction in A1C compared to canagliflozin. And this is from SUSTAIN 9 versus placebo as add-on to SGLT2 inhibitors and favoring semaglutide. And also when you look at the subjects achieving their target A1C of 7, less than 7%, again, the results are in favor of semaglutide versus canagliflozin and versus placebo as add-on to SGLT2 inhibitors. In terms of change of body weight and weight loss, semaglutide resulted in more weight loss compared to canagliflozin. And when it comes to the subjects of patients achieving more than 5%, actually it was comparable. This tells you how good canagliflozin actually is. But in SUSTAIN 9 versus placebo as add-on SGLT2 inhibitors, the result was in favor of semaglutide. Now, more importantly, if you look among the different GLP-1, the different weekly GLP-1 receptor agonists, how did semaglutide perform? So here we look at the result of SUSTAIN 3 and 7. So basically in SUSTAIN 3, the comparison was between semaglutide here versus exenatide, which is not available in Saudi Arabia. But again, there was significantly more A1C reduction with semaglutide versus exenatide. And what about dulaglutide, the other weekly GLP-1 that's available in the market? So with the lower doses of both dulaglutide and semaglutide, there was close to 0.5% additional reduction with semaglutide, and the same thing basically with the higher dose of both dulaglutide and semaglutide, 0.4% difference. In terms of change in body weight, again, in comparison to exenatide, there's significantly more weight loss with semaglutide. And also, when you look at dulaglutide at both doses, the change in body weight is significantly more with semaglutide. So what about the cardiovascular risk? Again, there was a lot of discussion, very interesting discussion with my colleagues about the cardiovascular risk. So cardiovascular disease remains the leading cause of death in patients with type 2 diabetes. And with the large, the growing number of patients with type 2 diabetes, this is going to continue to be a major challenge to our healthcare systems. So unfortunately, the awareness of cardiovascular risk from diabetes remains low. And on some studies, 50% of 50%, half patients type 2 diabetes recognize that they have an increased risk of cardiovascular disease. So we still need to do a better job educating our patients and spreading awareness about the importance of cardiovascular risk and managing the different risk factors, again, like my colleagues mentioned earlier, to optimize their cardiovascular status and reduce their cardiovascular events. So the guidelines, the diabetes guidelines, the cardiology guidelines emphasize and prioritize the cardiovascular risk management and the recent guidelines since the publication of the EMPA-REG outcome trials and the LEADER trial with liraglutide. If you look at the ADA guidelines, 2021 guidelines, you will see GLP-1 placed at different patient profiles, but most importantly here, at the first branching point in the algorithms, when there are indicators of high risk cardiovascular risk or established atherosclerotic cardiovascular disease or heart failure. So the SUSTAIN-6 trial is the CVOT, the cardiovascular outcome trial that evaluated the efficacy and safety of semaglutide. And this was a randomized, double-blind, placebo-controlled 4-arm trial, basically evaluating the 2 maintenance doses of semaglutide, the 1 milligram and 0.5 versus placebo. And the primary endpoint, which is standard now primary endpoint, is the time to first occurrence of 3-point MACE. MACE stands for major adverse cardiovascular events. And here the components are cardiovascular death, non-fatal MI, or non-fatal stroke. So what did the results show? So the hazard ratio here is 0.74. And basically this translates into a reduction of 26% in the primary outcome here, which is the 3-point MACE, when we compare semaglutide to the placebo arm. If we look more closely at the individual components of the primary outcome, the 3-point MACE, this was mainly driven by a reduction in non-fatal stroke. And again, the hazard ratio here is 0.61, basically, which translates to 39% reduction in non-fatal strokes comparing semaglutide to placebo. The NNT is calculated to be 45. Patients need to be treated for 2 years to prevent 1 cardiovascular death, non-fatal MI, or non-fatal stroke. That's the primary endpoint in the study. To illustrate how we might use semaglutide, this is a real case in my clinic. So this patient is HA. He's 41 years old, who had diabetes for 15 years, long-standing diabetes, unfortunately uncontrolled, with A1C of 12.6%. And he also suffers from obesity, class 1 obesity with a BMI of 34. He was on combination of vildagliptin and metformin at maximum doses, with also premixed insulin 50%, taking 30 units 3 times daily, so a total of 90 units. When we look at his labs, so his LDL was elevated, and he was actually not checking his glucose as often as he should, but his fasting was on average 200 milligram per deciliter or more, and his prandial was running more than 300 most of the time. So again, putting the patient at the center, we need to understand the patient concerns, what are his priority, what are the obstacles or challenges to achieving a better glycemic control. So obviously he was worried about his A1C. He's young, and he's worried about the possible complications of diabetes. He's also not happy about his weight. He's a banker. He comes home at 6 or 7 p.m. He doesn't have time to go to the gym, exercise, etc. A typical patient of ours. And he didn't want a more complicated regimen. He didn't want to go from 3 injections to basal bolus, 4 injection, basically. Otherwise, we would have issues with adherence. So again, it's a shared decision-making. We looked at his basically risks, and we went back to the guidelines. We discussed the different options. So we decided to set a goal of hemoglobin A1C of 7 achieving weight loss, and hopefully reducing his cardiovascular risk. So we decided to go ahead and initiate him on a GLP-1, and we chose Ozempic, since it offers the best A1C reduction and weight reduction in the class of GLP-1. I started with 0.25, and we titrated over a 3-month period to 1 milligram. I also added empagliflozin, an SGLT2 inhibitor, again, to potentiate the weight loss. And we stopped vildagliptin. So this is very important teaching point. When we use GLP-1, we stop DPP-4 inhibitors. So there is no point of combining these two classes. And anticipating that he would need less insulin, we decided to switch from premixed insulin to a long-acting insulin. In this case, we chose Tresiba. So what happened? So over the next months or so, his A1C actually started dropping very nicely from 12.6 to 8.2 to ending at 7.2%. His fasting glucose actually looked very beautiful, 90 to 120, on average 100 milligram per deciliter. And his postprandial, most of the time, were less than 140. He lost 18 kilos, which actually motivated him to join the gym, started training, and actually we continued to taper down his insulin. And the beautiful thing, he was not suffering from hypoglycemia despite being on insulin. So finally, just to add to the discussion with my colleagues regarding the issue of retinopathy with semaglutide. So this is actually from the FDA website. And as Dr. Walid mentioned, we see this phenomena with rapid glycemic control. This can result in temporary worsening of retinopathy or neuropathy. And actually there is an old terminology called insulin neuritis. That was seen before. Basically that happens, patients can develop neuropathy, painful neuropathy once they are in basal bolus, if they achieve tight, rapid glycemic control. And what the FDA, their conclusion basically was that based on these findings, there is no need to restrict semaglutide to specific population. So even those with retinopathy can still be on semaglutide. There is no need to give them a different dosing schedule, and the follow-up basically will remain the same. All our patients must have routine eye exam as per their basically, and the frequency depends on the basically severity of their retinopathy. So to summarize, basically semaglutide provided consistent glycemic improvement across the different SUSTAIN programs. Semaglutide resulted in significant weight loss across the SUSTAIN program. In SUSTAIN 6, semaglutide significantly reduced the risk of cardiovascular death. It met the primary endpoint of the trial. And semaglutide was well tolerated with safety profile that's typical of the other GLP-1 receptor agonists. Basically, the most frequent adverse events were those of GI nature. I'll stop here, and I'm more than happy to take any questions.
Thank you very much, Dr. Hussein. It's truly appreciated. Now I would like to invite all of our experts to the stage. And we got 7 minutes left before we conclude this very enriching, enlightening evening. Dr. Walid, I want one take-home message for us as a frontline primary care physician, putting it all together. What you would say to us about caring about our patient when it comes to using GLP as the line of treatment. Follow, Doctor.
First of all, I would like first, we need to always, I think, all the primary care physicians to, of course, looking for this kind of courses and self-development in treating more of diabetes, and develop the art, the new art for treating diabetes, and looking for the patient as holistic approach, addressing all the issues for the patient, and choose the proper medication for the proper patient in the right time. So that's what I advise. There's a huge change happen. What we are doing now is not like 10 years ago. There's quite different. Now, as a lot of our fellow, we have diabetes fellowship, almost now 2 years, is specialized in that part. Because these new changes happen in diabetes, we need to update ourselves always with this guideline. That's my advice.
Thank you very much. Very well taken. Dr. Saleh, advice from you to our colleague in the front line.
Okay, regarding as I opened the session, it's a hot topic, the use of GLP-1 receptor agonist in the world of diabetes. Mostly it's influenced by the healthcare providers and the media, and advocated this is a cardiovascular beneficial medication. It's acting like magic. We should put things in their context, okay? So not going to the extreme, okay, and to go with the evidence base, like our evening here. So I shed light on some of the side effect and some of the adverse effect, just to raise the awareness of our primary care providers and our patients, because some patients, they don't have any cardiovascular risk factors, they don't have established cardiovascular disease, and they are started on GLP-1 receptor agonist, and they're giving the wrong message. This will decrease your cardiovascular disease. By evidence and by the same CVOT trials, if you look to the sub-analysis of these trials, it doesn't decrease the cardiovascular risk in those who don't have established cardiovascular disease, except for the rewind, the dulaglutide, which can be viewed as a primary prevention. But for the others, it's only viewed as secondary prevention for the liraglutide and for the injectable semaglutide, even not the oral semaglutide. About the other, it has been conveyed the message that it decreased the microvascular complications. Mainly, it's the renal, okay, for the retinopathy, for liraglutide and dulaglutide, it doesn't increase the risk of retinopathy significantly. For the injectable semaglutide, it does increase significantly, and it was explained by Dr. Walid and Dr. Hussein. And for the oral semaglutide, the subsequent trial, they exclude already those who having vitreous hemorrhage and maculopathy. About the renal, it has been said that it's decreasing the risk of nephropathy. It's mainly by albuminuria. It doesn't decline the GFR, okay? And one thing, be cautious. In those who's having GFR below 30, especially, we have limited experience. It's not recommended to be initiated. There are post-marketing cases of acute kidney injury, okay, because of the dehydration, nausea, vomiting, the common side effect of this GLP-1 receptor. And those with advanced kidney disease, it might induce acute kidney injury on top of that. Okay, so for take-home message, it's a wonderful medication. It's magic in restoring the beta cell function. It has durable effect. It promotes weight loss. It has a secondary cardiovascular prevention, but we need to counterbalance and be cautious about the possible side effect and to counsel our patient about this side effect. It has been, I would like to shed light on some practice. They are requesting thyroid ultrasound, requesting thyroid function before initiating it. It's not recommended. It's by history, personal or family history of medullary thyroid cancer or MIN type 2, it's the contraindicated, no other thyroid disease. Some of them, they got hypothyroidism or other diseases of thyroid. It's not a contraindication. And it's wrong practice to request routine thyroid ultrasound or to request routine calcitonin level or request or monitoring routinely the lipase amylase. Last thing, most of these trials, they exclude patients with class 4 heart failure, with advanced stage of heart failure and chronic heart failure. Class 4, they were excluded. And all these trials, those who having heart failure, they represent 20% of all study population. Okay, so, and the message they are conveying from these trials, they don't increase risk of heart failure hospitalization for those who's having class 2 or class 3. So heart failure is a clinical diagnosis. In your history, you should take history of thyroid disease, history
Dr.
of
Saleh, thank you very much. I want a message. You gave me a very brief summary of the whole thing. So thank you. Dr. Umar, one take-home message, what it will be from your side?
My advice will be use what is available for you. Use the guideline that was developed by a group of colleagues who go through whatever you are going through in your daily practice. And use this guideline to look with your patient, with your consultant, with your trainer, with your colleague. This will keep reminding you of the fundamentals and, as Dr. Walid said, the art of using the primary care knife, which is the prescription. The other message I want to send out, Abu Abdul Malik, I know, alhamdulillah, we live in a very well-off country. We are rich. We can afford to buy all medications. But I think diabetes should be managed at a national level. And I would love to see a group of people working on a national prescription which will minimize the variation in practice and will end up the monopoly of who you go to see, or and at the other and it will always remind the practitioner of what to check for, and it's not too difficult to establish. Thank you, Abu.
Thank you, Dr. Hussein. Take home message.
Thank you very much, Dr. Hadi. So I think we talked a lot about GLP-1. I'm not going to repeat what was said earlier, but I just want to remind everyone, primary care and the primary care field, please always remember to emphasize lifestyle changes. It is still the foundation of all the intervention we can offer to our patients. We have great tools now at our disposal. We can do a lot to help our patients, but lifestyle remains the foundation.
Thank you very much. Thank you very much, our great expert colleague. It was very rich evening. I want to capitalize on what started as a take-home message from Dr. Walid, elaborated more by Dr. Saleh, linked to the guidelines by Dr. Umar, then concluded by the re-emphasizing on a very cornerstone of lifestyle. This evening, I want our colleague up there in primary care to take it as an orientation and eye-opener. And I will just advise what's mentioned by Dr. Walid. Let's get engaged in more enriching our experience through educational activity, through talking to our colleague expert, through referring to the guidelines. We at the society, we are very open. We'll make every single effort to work with everybody who wants to provide education to our frontliners. That be like this evening, was sponsored by one of the great company, Novo Nordisk, through the CCHI, through the university, through the Ministry of Health. Whoever is extending hand to help us reach to the wider primary care, we're very open. And I want to take this opportunity to thank again our speaker. And I want to make sure you all get an opportunity to look at our big national gathering of family physicians across the country. It's coming very soon. In 2 days, June 11, going to be the day one, where we're going to talk about all the urgent care that are expected to be seen by the primary care physician. So it's a full day of the virtual. Then we're going to take you through day 2 about the chronic. So we're going to talk about hypertension, where we're going to show you our national guidelines. We're going to talk about headache, where we also have our national guidelines. The asthma, the smoking cessation, the health prevention that was mentioned by our colleague, the lipids, the COPD, and the anemia, and obesity, diabetes. We're going to re-emphasize again the depression. So it's the whole chronic disease that's going to be presented to you. Now, on day 3, it's going to be very interesting to focus on women and children. Whatever you need to do for the kids, from family planning, infection, all the infection that you're gonna face in the women's and children. And we kept a very important and enriching day on day 4. We're gonna tackle specific topics that are needed for the rheumatology, hormone disorder, skin disorder, eye problem, ENT problem. So please make sure to mark your calendar. Join us in this very big national gathering where we excited all our colleagues. Thank you very much once again, Dr. Walid. Thank you very much, Dr. Saleh. Thank you very much, Dr. Umar. Thank you very much, Dr. Hussein. Thank you very much, our great sponsor for the evening. أستودعكم.
This is Dr. Khalid Al-Nizzi. I'm the chairman of the scientific and organizing committee for the DD21. Lots of people ask me what's special about this version of the deep dive. Well, I can summarize it in 3 points. Number 1, it is very clinically oriented, and we built it around the 6 domains of model of cares and themes. So for example, if you came day 1, it's going to be urgent care, followed by chronic, women and children, and then miscellaneous. For all the practitioners in the primary care across the country will find it quite relevant to them. Number 2, we stay committed to our promise to our trainees to make this conference very well oriented to their exam. So those who are sitting for any promotion or final exam in the field of family medicine, they will find this conference quite relevant to them. Finally, this conference endorsed by the all major and leading organization in the country. The holding company, شركة الصحة القابضة, CCHI, المجلس الصحي السعودي, and the Saudi Commission for Healthcare Specialty. So I can say it is the largest gathering for family, physician, and primary care across the country. See you all on June 11.
للسماء يا ديرة العز والمجد التلي يوم ابو تركي رقى للمعالي ونالها ورث ملوك لهم بالعلا شان ورصيد هم ملوك العز وبالنايبات جبالها وبالنايبات